Good morning. Thanks for the organizers for having me. Correct, I do have home field advantage because I am the non-interventionalist advocating for endovascular thrombectomy here. These are my disclosures. The most important is I am the PI for the SELECT-2 trial, which is specifically looking at endovascular thrombectomy in large core randomized trial. So I should and I will maintain a certain level of equipoise here. So talking about true reversal, it seems Lucas really did a good job. The non-interventionalist is advocating for endovascular thrombectomy, while the interventionalist is the one who is saying we should not treat. It's like the man pulling the cart with the horse in it. My opponent and friend Dr. Hussain will tell you a few things, and I thought I will take it away from his hand in advance. He will say that there is lack of evidence, and it's true. Those patients with large core were largely excluded from clinical trials with low aspects, with core volume more than 50 or 70. Those large strokes come in, whether you treat with CT or CTP, you're going to see that large area or not in the clinical trials. This is from Dr. Campbell showing the core infarcts in the clinical trials and showing that most of the patients, largely more than 90% of the patients, were then less than 50 cc. So yes, there is lack of evidence from clinical trials. There are safety concerns, absolutely. The risk of hemorrhagic transformation is higher in these patients, and those are very valid arguments. But there are signals towards benefit in this population. If you look at large core based on CT, yeah, there were some patients with an aspect of 3 to 5, and you see this paper from the Hermes showing signal towards benefit, not so much in aspect 0 to 2, but limited number of patients with statistically significant odd ratios and so confidence intervals not for aspect 0 to 2. If you treat with CTP, Dr. Campbell provide you with this limited number of patients, but signal towards benefit in patients with large core, 80% versus 0%, something, but it's only 50 patients. Now, Dr. Hussain will claim that endovascular thrombectomy will not result in the pristine results that you get when you treat patients with small core. This is true. In the SELECT study, we looked at the patients with small core that were enrolled in the clinical trials versus the ones with the large core, 59% with very poor outcome of around 13% versus 31% and very poor outcome of 35%. So this is true, and this also translates not only to the good outcome, the symptomatic hemorrhage rate is higher, the neurological worsening is higher, and the mortality is higher. But the myth here and the mistake is you're comparing thrombectomy to thrombectomy. You should look at the natural history in these patients and what happens if you don't treat them. Let's look at large core in thrombectomy versus large core in medical management, 31% versus 14%, and the very poor outcome also drops with thrombectomy from 54 to 35%. And that goes along with the other outcomes, including the mortality dropping and the neurological worsening. This is a prospective phase 2 evidence that we published in the SELECT study in patients with large core. We have 105 patients, non-randomized, and we are now doing the randomized phase. And if you look at the good outcome with thrombectomy was around 31%, medical management was around 14%. So yes, you're not getting your 50, 60% good outcome, but it's a shift towards better outcome in all of the modified Rankin scales. And that was statistically significant, non-randomized, but this is how the evidence starts and evolve. That was also true for you may not end up with MRS of 0 to 2, but the infarct will be smaller. You might be saving the patient from a hemicrania. You may be saving the patient from death. Also, the infarct volume growth from arrival to post-procedure was lower. So what about, if you are a CT or CTP believer, same with the aspect less than 6, we found 35% versus 18%. So Same absolute difference. You're not going to find statistical significance with 70 patients, but the signal was towards better outcome with thrombectomy. Also, the safety profile was good, lower symptomatic hemorrhage rate. Same for large core with large core on CTP. You may say that CTP nailed it. I don't have very good outcome with or a rate in medical management, but the absolute difference is around 15 to 18% in both, with similar safety profile and lower symptomatic hemorrhage rate with thrombectomy. Should you treat everyone? Absolutely not. This is from the SELECT paper. We looked at the effect of time and core size. This is a 3D figure that's showing you the probability of good outcome as time progresses and as volume progresses. Every hour delay associated with decrease of likelihood of good outcome by 40%, and every 10 cc increase in volume on perfusion was associated with 42% decreased likelihood of good outcome with thrombectomy. And Dr. Campbell did a nice commentary on this, selecting patients, treating them earlier, treating them with certain volume. So what should you believe? You should believe whatever I told you and not what Dr. Hussain will tell you. You should believe that there is preliminary evidence for potential efficacy with reasonable safety in these patients. Yes, there are lower rates of functional independence, but we're now expanding from treating the perfect patient to treating the one who is less perfect, probably better than letting the nature takes its course. Time matters, size matters, and there are ongoing trials. There's tension in extremis, Tesla, and SELECT-2, which Dr. Hussain is on a steering committee and interventional committee and part of the study. So we're working together on resolving our disagreement here. And use your best judgment and select patients whenever you have the chance. Do randomize. And just to prove to you that we're friends, this is from our romantic getaway to Como. George Clooney was the one taking the picture. Thank you.